Welcome back, everyone. It's Robbie and Reza. In part 1, we met a patient with severe bilateral scrotal pain, a presentation that can hide some of the most urgent diagnoses in medicine. Today, we're revealing the final diagnosis and walking through a structured approach to acute scrotal pain that could save a life. We're not urologists, but by the end of this episode, you'll have a simple mental framework for approaching acute scrotal pain, covering the most common and the most life-threatening causes. Let's start broadly. When you hear acute scrotal pain, there are 3 diagnoses you must always consider. Number 1, testicular torsion. When the testis twists on the spermatocord, which houses the blood supply to the testicles, cutting off its own blood supply, leading to rapid ischemia. This is a true surgical emergency. Number 2, acute epididymitis plus minus orchitis. The epididymis is a coiled tube located in the back of each testis that stores and carries sperm. When it becomes inflamed, it causes significant pain and swelling. We always consider the common causes of acute scrotal pain based on their frequency, but we can be more specific in framing the problem and refining the differential diagnosis. First ask, is the pain primary or referred? This is a major concept in clinical reasoning for pain anywhere. You can often tell by looking. If the genital exam is abnormal, you're likely dealing with primary pathology of the scrotum. In our patient, the scrotum was red and swollen, so this was clearly primary. The next branch is whether the pain is unilateral or bilateral. Our case was bilateral, which takes us down the bilateral path, where the big categories are fluid overload, infection, and drug reaction. Scrotal infections can be limited to the skin and subcutaneous tissue, like cellulitis, or they can extend deeper, involving the fascia. Now here's the importance of the HPI. 5 days earlier, our patient placed a tight ring around his genitals, cutting off blood supply, causing tissue injury, and creating a perfect environment for bacteria to invade. Why perfect? The skin barrier, our primary defense, was breached, allowing aerobic organisms from the skin to enter, while the reduced blood flow limited immune cell access. At the same time, the resulting low oxygen environment favored the growth of anaerobic bacteria, and his diabetes, a known risk factor for aggressive infections, and we are already on high alert. The labs pushed the story forward. His white blood cell count was 18,000 and neutrophil predominant. His serum sodium was 118, indicating hyponatremia, and his glucose 345 with an A1C of 12%, showing uncontrolled diabetes. Hyponatremia here is an important clue. It can appear in severe infections like necrotizing fasciitis. Why? Deep infections trigger cytokine-induced leaky capillaries, leading to massive third spacing and hypovolemia, which in turn drives non-osmotic antidiuretic hormone release and thirst, resulting in dilutional hyponatremia. I'm going to repeat this because the pathophysiology is beautiful. Deep infection, leaky capillaries, third spacing and hypovolemia, ADH secretion and thirst, resulting in dilutional hyponatremia. We ordered an ultrasound, which showed severe scrotal edema, but no epididymitis. But is ultrasound enough to rule out necrotizing fasciitis? It can suggest it by showing subcutaneous gas, but its sensitivity is far from perfect, so a negative result does not rule it out. Given our high suspicion, we proceeded with a CT abdomen and pelvis with contrast, which revealed fat stranding extending from the scrotum into the perineum and deep into the gluteal region. This was Fournier's gangrene until proven otherwise. If the CT had been negative, the pretest probability was so high that the next step would still be immediate surgical exploration or repeat imaging at the first sign of any clinical change. Let's tie it all together. The tight ring injured the tissue and reduced blood flow, creating a perfect setup for infection. Diabetes impaired his immune defenses. Hyponatremia signaled a severe systemic infection, and imaging confirmed deep space involvement along fascial planes. High pretest probability for a life-threatening condition plus compatible findings means you don't delay surgery. Fournier's gangrene is named after Jean-Alfred Fournier, the French physician who first described this condition in 1883. It most often affects people with diabetes, like our patient, those who have chronic Foley catheters, or who have recent trauma from instrumentation of the urethra, especially if a urinary tract infection is also present. It occurs when a break in the skin or mucosa, whether from trauma, surgery, or devices, gives bacteria an entry point, allowing a mix of aerobic and anaerobic organisms to rapidly spread along the fascial planes of the perineum and genitalia. The perineum is the area between the pubic symphysis and the coccyx. Essentially, the space between the genitals and the anus, containing important muscles, nerves, and blood vessels. Infection spreads so quickly because the superficial fascia of the scrotum is continuous with the fascia of the penis, perineum, lower abdominal wall, and even into the thighs, creating highways for rapid extension without obvious early skin changes. Presentation includes severe, often disproportionate pain in the genitalia or the perineal area, swelling, redness, tense skin, and sometimes blister or bullae. As it advances, crepitus and systemic toxicity may develop. Progression can occur over hours, and the earlier it is recognized and treated, the better the outcome. Diagnosis is clinical, so do not delay surgery for imaging if your suspicion is high. Though CT or MRI can help define extent, sometimes showing air along fascial planes or deep tissue involvement. Treatment is immediate surgical exploration with excessive debridement, plus broad-spectrum antibiotics. With early recognition and treatment, mortality is around 20%, but delays can push it above 50%. People die because infection spreads fast, releases powerful toxins, and drives the body into septic shock before you can catch up. And you really can't wait for all those findings to appear on the skin because the problem starts in the fascia and builds outward. Fournier gangrene is rare but deadly, and it sits along torsion and epididymitis as the top causes of acute scrotal pain. If you remember one thing from today, when the stories in labs scream danger, don't let a negative test, imaging, lull you into complacency. And remember this, study a little today so you're smarter tomorrow than you were yesterday. See you next time.
That's a wrap, folks.